I used to have a pile of maps in my car. I would use them to go from my home to point A to B as I was traveling around the state. But now I don't really use those maps anymore. Instead, I have my GPS, which I use, and it provides me with a lot more information. I miss my maps. They're really a relic of the past, but with a GPS, I can know about traffic, about accidents, about tolls, about all kinds of barriers that those paper maps really didn't display for me. And it's also good for someone who wants to use it for a different purpose, like maybe walking or taking mass transit, somebody who has more particularized needs than I do. And I think about the intersection between healthcare and data, much as how I think about those maps of mine. Maps can really just give you that big simplistic picture, kind of like aggregated statewide data. Aggregated statewide data can tell us something like what the state average is for teenage pregnancy or smoking or obesity. But when we really want to do something about those important public health issues, when we really want to look into them and make policy changes and identify those populations that are at most at risk, we really need something a lot deeper. We really need more of a GPS for public health. And that's really what I want to share with you today, how we look at those fuller pictures. In my day job, I'm the president and CEO of the New Jersey Healthcare Quality Institute. The Institute is a nonprofit that's focused on improving the quality, safety, and affordability of health care for everyone. And we look at a lot of data to improve the quality of life for people in New Jersey. One of the types of data that I started looking into a number of years ago, and which is of great interest to me, was maternity care data. It's funny, I never really thought about it before I started looking into this topic, but maternity care is the most common reason why anybody would be in a hospital across the U.S. And so looking at maternal care data, particularly hospital quality data, is a really important measure to look at. When I started to look at New Jersey's data, one of the things that stood out is our C-section rate data. Another reason why we look at the quality of maternity care is because the New Jersey Healthcare Quality Institute is the regional leader for Leapfrog. And Leapfrog is a nonprofit organization focused on patient safety. And they produce an annual report which has 5 measures of maternal quality among a whole lot of other safety measures. And in looking at New Jersey's maternal quality and safety across the state, what we saw hospital by hospital was that New Jersey was not stacking up well and had a pretty far way to go to improving its quality. The maternity C-section rate, which is also known as the NTSV rate, looks at what percentage of lower risk births, so these are births of women, by women, their first birth, a single baby, so not twins, head down position. And the recommended NTSV rate is 23.9%, which means that for that group of births, not more than 23.9% of them should end up with a C-section. And if they do end up with a C-section, it means that something's going on at your hospital which is making you have a higher use of medical interventions, surgical interventions. So it's important to take a look at that. Why is this important, though? Let me just talk about that for a little bit. When we first started looking at this issue and started asking questions about why our rate was so high, we got a lot of pushback from certain healthcare leaders. We were told that it was the way it was because this is what women wanted, that women were busier these days, that women were working now, and they liked to schedule when they had their baby. But when we looked at the data and we looked at the fact that certain hospitals really were meeting this benchmark and others were not, and when we looked at the qualitative data and the surveys about what women reported that they really wanted, we saw that these excuses were really not the case, and it was really something else. So we kept pushing and looking at the data. And why does this matter? Why is this even a quality measure to begin with? Shouldn't this just be a matter of preference? While C-sections are necessary in certain instances, and they can often be life-saving in those instances, if a woman can avoid having an unnecessary surgery, there are significant health benefits to both the patient and the infant to not having an unnecessary surgery. Those include a faster recovery, lower risk of blood clots, lower complication rates, reduced infection rates, and a less pain after childbirth. So looking at our NTSV rates today here in New Jersey, they have improved. We're at 27.8%, which is a big improvement. But again, this number that I just gave you is really a big picture aggregated number, like a map, like my map of days gone by. And what we really need to do to improve policy and to move forward is to take that nuanced, deeper dive GPS look at the data to see what policy changes we need and what directions we need to go. And when we take that nuanced dive, we see that we do have a long way to go still. And I really want to thank New Jersey's Department of Health, because the data I'm going to share with you is that deeper GPS look, which they are providing to us now on the State Department of Health Maternal Mortality and Morbidity and Hospital Report Card website, which is a very usable website to really dig into this data, and that's what I did. And the first example that I want to share was I started to dig into the data and was really struck by what I saw at a hospital in South Jersey. This hospital, its patient population, of pregnant women giving birth there, is about 40% white, 30% black, 20% Hispanic, and 8 or 9% Asian. The population insurance-wise, about half of the patients have private insurance, usually from an employer. The other half are some kind of a public insurance like Medicaid. Looking at all the other differentiations, education was one of them. There really were no differences in outcomes. Age did make somewhat of a difference, but the real variation was race. And when you look at race and you look at that NTSV rate, you see that 40% of black women who went to that hospital for their delivery ended up with a C-section, NTSV rate, C-section. Whereas for white women, it was 27%, and for Hispanic women, it was 28.8%, and their overall rate was 29.9. So 29.9 is still much higher than the benchmark, the target of 23.9, but it's much better than 40%. So black women walking into that hospital have significantly worse outcomes than white women when it comes to that NTSV rate. And again, The reason why this matters is because being able to avoid a surgery can make a real difference in the quality and safety outcomes for both the woman and the infant. You can avoid complications, blood clots, infections, and all of these things can be life-threatening events. So continuing down our journey, when we start to look at this data in this deeper way, it leads us to ask some really important policy questions and how the data can help us come up with the answers, and to drill down on questions like, why are some hospitals that are just miles apart from one another doing so differently in terms of quality measures when it comes to serving pregnant patients in New Jersey? And why are hospitals where the communities that they serve can be so similar, those same communities, very similar populations, and end up with such different outcomes, and such different outcomes within that community based on race? And what are those hospitals which are more successful doing differently, and how can we learn from those hospitals, and how can we apply our programs and our resources in a way to improve those others that need help and improvement? So I want to take you now on a journey that I took talking to 3 successful hospitals in New Jersey that by looking at their data and then interviewing them, we found really were making a difference in terms of quality improvement. And the first is from a hospital in Central Jersey. This hospital is a high-volume hospital that has strong nurse and physician leadership. And what the physicians and nurses in this hospital saw a number of years ago was that they too had a quality problem. But they knew that their colleagues would not listen to them unless they had the data to back up what their recommendations were. So they spent months and really years sharing the data, comparing their physicians to one another, showing how they compared to their peers, and really discussing and highlighting what the data was showing and the changes that need to be made. And from that, they identified not only culture change that needed to happen and then did happen, but they also identified that their problem was staffing related, and that they needed to create a program to support their physicians so that women who were in the hospital had time to labor and they weren't rushed into having a surgical procedure that maybe wasn't necessary. So they created a 24/7 laborist program within the hospital to support women as well as their staff, and continued to see that investment pay off. Another hospital that we visited, whose journey I want to share with you, is in northern New Jersey. This hospital has the highest risk patients in the state. This is not a luxury hospital. It doesn't have private rooms or beautiful views out its window. But what it has is an environment of using data in the spirit of learning and quality improvement. For every C-section that occurs in their hospital each week, they gather together the nurses, the physicians, the residents, and they discuss each C-section, what happened, whether it was necessary, what was done, and why. And through that collaborative learning process, without a focus of blame, but a focus of looking into the data and what you can glean by it, they have one of the lowest NTSV rates in the state and are really a leader that teaches other hospitals across the state. And finally, another hospital that we met with in North Jersey, which also uses data, beyond looking at the data to communicate with its physicians and nurses, they also dug into their patient data to identify certain barriers and risks for patients, and they saw that some of their higher risk patients were not seeking postpartum care. And the reason why that's concerning and matters is because over 50% of the maternal deaths that occur in the postpartum period. So it's very important for women to get postpartum care. They were able to see that while they weren't seeing those patients come back, those same patients were taking their infants to the pediatrician, the pediatric clinic that was right down the hall from the maternal clinic. So what they ended up doing was they shifted their pattern of practice, and they sent their nurses and doctors down to the pediatric clinic and saw those women while they were there bringing their babies in. So really using the data to create new creative programs to really make a difference in those women's lives. And finally, the other thing that data can do, besides improving quality in the ways that I just mentioned, is it's also able to shine a light on these disparities, such as the first example I gave you about the racial differences in the NTSV rates. And through that shining of the light, creating public pressure. Now, through this focus on these disparities, our current First Lady, Tammy Murphy, has made it her #1 priority to reduce Black maternal mortality and to make New Jersey the safest place in the United States to have a baby. And some of the interventions that her current program is focusing on to address these disparities are things like investments in doula programs and centering programs, which are evidence-based programs, which are group visits to support pregnant women. The other way that data is used in these programs is to really identify which communities have the greatest need for this type of investment. And finally, the Quality Institute is currently working with NJIT and NJII on a program using data to create a perinatal risk assessment tool, which is a tool that's going to be used universally across New Jersey by health plans, providers, hospitals, and the state to really look at data, to risk assess patients, and then identify what medical as well as social service needs are going to be most helpful to those pregnant women. As you can see, having that nuanced data, that GPS level data, is really what we're going to need to drive this difficult change, but difficult change that has to happen. And hopefully, for the sake of our next generation, we're not going to get lost because we have that data to guide us. Thanks.